Okay. Hi, everybody. This is Kelly Puente with the Long Beach Post, and I'm here with Dr. Mauricio Heilbron, better known as Dr. Mo. He's a trauma surgeon at St. Mary Medical Center and has been a frequent commentator on with the radio and has talked to us a lot about some of his expertise and what he's seeing. So we're going to talk today a little bit about the vaccine, about what Dr. Mo has been seeing on the ground, and just about some concerns moving forward and what we can expect. And send us your questions on Facebook, and we'll try to get them answered. Well, Dr. Mo, thanks so much for joining us. Appreciate it. Always a pleasure to have you. So the big news this week, obviously the vaccine coming out, and Long Beach on Thursday just unveiled its plan to roll out the vaccine. We're going to get over 3,000 doses with the Pfizer vaccine. Hopefully, if they approve it, they get off their butts and approve it within the next few weeks, we could get it. So as far as Long Beach's plan, the way they're going to give it to healthcare workers, essential workers, how do you feel about Long Beach, the way with our own health department, how we're going to be doing this?
Well, I remain hopeful. I'm going to wait and see how it actually rolls out, because nowadays, things change on the fly. Mm-hmm. But it seems like they're going to be proactive about it. It seems like they really want to get it to the people that need it first responders, healthcare workers, nursing homes. The fact of the matter is we have to see how it gets rolled out. How does it physically get to the United States? How does it get spread? How does it get to the people that can deliver it? That remains to be seen. But in terms of a plan, let's do it. I'm excited.
One of the things that kind of concerned me a little bit is that the vaccine I read that it hasn't been tested on elderly people, seniors, and those are going to be among some of the first to get it. I think in England, it was a 90-year-old grandmother that was the first to get it. But is that a little concerning that this hasn't been tested on the first people that are essentially going to get it?
It's not that concerning in that this is the first time the lay public actually sees how the sausage is made. This is the first time you guys see how we make drugs and make vaccines. So when you are studying and trying a vaccine, you don't give it to the elderly because you're trying to see how it works. You're trying to see in what percentage does it offer a benefit. So that doesn't surprise me. So yeah, I hear your concerns, but that's not the way you do the research.
Got it. Okay, and as far as just what you're seeing is with the vaccines and studies and results, do you feel like this is promising? Is this something that could work? And
oh no, I'm cautiously, ridiculously optimistic, if that makes any sense at all, because I haven't seen the actual numbers. I'm not on the FDA. I'm not one of those important people like Sanjay Gupta, but I have seen the interim results. I've seen the stuff that's been published, and there's a couple things that even a layperson can take out of the initial stuff. One, they gave the vaccine to a lot of people, and not a lot of people got sick. There was some reports of 24 hours of feeling kind of crappy, but I get that with the flu shot, so that's fine. So one thing we can say is the study does show that it's safe. FDA is going to want to hear that. I think that's what they heard and that's what they like. Number two, if you look at the numbers, they tested the people that had symptoms to see whether or not they had COVID, right? So they didn't test everybody. They only tested the people that had symptoms. Of the people that had symptoms, there were a lot less in the vaccine group. It was something like 11 in one group and 182 in the placebo group. That's a big number. It's not that big when you compare it to 15,000, which is the number of people that actually got the vaccine. But let's just go with it. The number of people that got sick is a lot less if you got a vaccine, 90-something% less. So I think we should move initially away from, am I going to be immune from COVID? Am I going to be immunized? No. But what you can say is, if I get it, it's going to be way less. And I may not even have symptoms. That's what I think we need to focus on first.
I think that's one of the big misconceptions. People think they're going to get this and then they're just automatically immune. They can go to a rave or go out and party. But so it's not a foolproof. You could still get it. You could still spread it.
Yeah, and that's what those studies will come later, because those studies talk about asymptomatic patients and asymptomatic spread, and none of those were tested. But that's not what you want to test the first time around. The first time around is, can we do something to slow this down? And that's what's really encouraging about this. And that's what I think you can sense in some of the other people you see on TV, some of the people at the FDA, Dr. Fauci, Dr. Gupta, some of these other like important doctors are genuinely enthusiastic. And I think this is why. I don't think it's going to mean that we can get back to normal, but I think it's a huge first step, a huge first step.
And as far as just the rollout, I mean, it's taking forever to just get the approval. They're supposed to do it today, they said, by the end of the day. But do you see the general public getting this by some estimates, they say by the end of next spring?
But see, that's funny that you say it seems like it's taking forever. So FDA approval normally takes 4 to 6 months, and they did it in a week and a half. So they're really moving this faster than we've ever seen before. So normally we wouldn't see this for a year. The fact that we're talking about it in a week to 2 to 3 months is huge. But again, we actually have to see if they can pull this off. We have to, I'm not gonna, you can call, I will let you know as soon as I get my shot. I'll tell you how it works. Yeah. If I get one, I will let you know.
Well, as far as, so the vaccine looks promising. Hopefully we can get that very soon. But just let's talk a little bit about just the numbers right now. Terrifying. I mean, we're down to, I think it's a 6% ICU capacity now in LA County. Orange County is getting flooded. It's turning into a nightmare. What are some of the things that you're seeing on the ground as far as just people coming into the hospital, or can you, just paint a little bit of a picture for us of what it looks like as a first responder?
So yeah, there's a more global picture that I hear from my colleagues all over the place, and then what I'm actually seeing in our hospital. Because if I'm being really honest, we learned last time around. So we're busy and we got a lot of patients, but we're handling the surge. So it's not like we're sitting around picking our noses. We're super busy. There's a lot of sick patients. I took care of some over the weekend in the intensive care units, and we're busy. But we're not like LA County up north to us. We're not getting what's happening in Orange County. But that can change every hour. That can change every day. And I have some of my friends in other cities and other states that are frightened. The numbers are starting to get overwhelming. And it's hard for people who are sitting at home looking around going, I just want to go to my favorite restaurant, to understand that this isn't about them. I mean, it is kind of about, it's hard for, I want to grab people and bring them to the intensive care unit and show them people how sick they are. I want to see how crowded these ICUs are getting up in LA County, or even in the Midwest. I mean, you hear some of these horrifying stories of South Dakota where they're not built for this. At least LA County, we're used to biblical disasters all the time in our hospitals around here. I work at a trauma center. Memorial's a trauma center. We're used to dealing with the worst of the worst. We're hospitals that are built for heart attacks, for strokes, for the sickest. So we can handle that. But imagine if you're like in Sturgis, South Dakota, and you have 4 ICU beds. That's what's horrifying, because that bed somebody else might need for a heart attack. That bed somebody might else need for a motorcycle accident, and that bed's not there. What are we going to do with those patients? And that's this avalanche that I'm really worried about, especially in this post-Thanksgiving period when so many people traveled, and we're not going to see we're starting to see the effects right now. And I think the worst is going to happen in about 7 days.
In 7 days, you feel like in the next week? You think?
I'm guessing, because it's usually about 14 to 21 days after we start seeing these numbers, and then another 7 to 10 days after how many of the people are sick enough to be in the hospital, and then even further, how many of the people in the hospital end up dead.
Wow. So you've definitely seen an increase in patients.
Oh yeah, it's busy.
At what point do you feel, with the numbers going the way they are, that you could eventually become overwhelmed, even at hospitals that are built for it, like St. Mary?
I think we have to say yes, because we keep thinking it peaks and every day there's more. We learned something a couple months ago, so all hospitals are a little bit more prepared. But there gets to a point where it's just numbers, and it's not the rooms. And people forget it's the people that actually work there. It's the nurse. I mean, our nurses are worked to the bone. They are.
What's the feeling amongst the staff there? I mean, are they just exhausted? Are they, I mean, how are they feeling there?
It's people call healthcare workers heroes a lot nowadays. And even at the coffee shop the other day, it says, I was in my scrubs and somebody said, thank you for your service. I was like, this is what I'm supposed to do. I mean, thank you, because I got a lot of people calling me a sheep and all this other stuff. So thank you for saying something nice. But the reality is, it's the people that are the residents, the house staff that's in the hospital, the nurses that are there dealing with it and having to deal with more work than they had planned. The housekeepers that they're getting shuttled around trying to keep up with, keeping rooms open, keeping rooms clean, getting them ready for the next patient. And we're not as staffed as we could be. And people are going to start getting sick. Nurses are going to get sick. Housekeepers are going to get sick. Doctors are going to get sick. They have been. Not at rates like anybody else, because we tend to wear masks all the time. So, I mean, I'm a surgeon. I'm fine wearing a mask all the time. I don't have a problem with that. But I understand I'm used to it, and some people aren't. Sorry about the truck in the background.
Okay.
So the overall mood, it's sort of this wartime in the trenches. We're going to support each other, get through this, and do what we can.
Wow. And at least, and one of the promising things is that they've gotten better, faster at treating people. There's more treatments available now. Can maybe tell me a couple little things that you have that they've gotten better, that they've learned, which have helped patients?
Excellent point. One of the reasons we made some differences in the last couple of months on death rates, because a lot of people analyze all the numbers and stuff. Doctors and hospitals and nurses and scientists have gotten better at dealing with the complications of COVID. We're getting better at managing the pulmonary complications. We're finding, I don't know if you saw the recent report from the World Health Organization, that a lot of the drugs we had put our hopes on ultimately don't do that much good.
Oh, really?
Yeah, they had an article about hydroxychloroquine and remdesivir and stuff that you have to let research play out. We need to know how it works in the long term.
Remdesivir was supposed to be one of the most promising ones. That's the one that people were really excited about.
But doesn't it seem like everything's promising?
Well, I guess right now everything, we just want hope for anything.
But that's, again, you guys, you meaning the lay people, don't see how this is normally done. And normally this happens in the background and takes years and is carefully poured over. And now somebody can put something up on a Facebook page and it becomes something to talk about. So it's a completely different way of doing medicine. But having said that, our ICU doctors are better now. Our nurses are more experienced now. We're handling this better. But for example, we're finding these weird cases of COVID patients where the blood clots in their arteries and we have to amputate their limbs.
What? Wow.
Now, yeah, you say wow, but we do that, and we've done it for other illnesses too. It sucks, but imagine these are the people that will tell me, "Hey, these patients recovered." I was like, recovered at what cost? And that's why when they look at the statistics, officially that patient recovered, but they have a trach and they're missing a leg. So
we haven't seen that here in Long Beach, have we?
Huh?
Have we seen that here in Long Beach?
Oh, absolutely. We're seeing it everywhere. We get the sickest of the sick.
Gosh.
And it's not that rare. We see it. Now we're seeing it with COVID. We've seen it. Again, it just doesn't show up on other people's radar.
Yeah, that's really scary to think
Really
that people are having limbs amputated. I don't think I've really even heard of that.
Oh yeah.
There's so much people don't know about this still.
Yeah, well, I'll give you the reason it happens just really quick is that some people get so sick that whatever infection that it is races through their body and their blood pressure drops so much that they can't even get enough blood going to their brain and their heart to keep them alive. So we give them drugs that artificially elevate their blood pressure. And what those do, if you can imagine, is it constricts all of your blood vessels to shove all the blood that you have towards things you need, like your brain, like your kidneys, like your heart. But what it does is it squeezes off the tiniest ones in your fingers and your toes, and they start getting gangrenous. So in order to keep you alive, you're going to lose stuff.
Gosh.
We did that before for other diseases, and we do it now for COVID because people are that sick. We're better at keeping them alive, and they show up in the statistics as a recovery, but it's a qualified recovery. And late data, 1, 2, 3 years from now, when we can really analyze all this stuff, we'll have a better picture of what's going on. But this is sometimes when you hear doctors who are looking scared, like me, I'm genuinely concerned. I to the point, and this sounds dramatic, but again, and it probably is, but I got called in the middle of the night the other night to put a giant IV in a dying COVID patient to try to keep him alive.
Oh, wow. And
on my way there, I jotted an email to my lawyer saying, if I get sick and a couple weeks later I don't make it through this, this is when I think this happened.
Oh,
I know. Now he's fine, and the patient's actually alive and doing great and turned around and looks like he's good. Hopefully he's going to be okay. But this is the stuff that we're dealing with now. In the operating room, seeing people wearing spacesuits to try to take a leg off. Like I said, that happened not too long ago. We're in weird times.
So you must worry that you're going to get it constantly. Your family probably worries about you. What do you?
I'm worried but 99.9% of the time, I'm anal about this stuff. I'm wearing my masks. I wash my hands all the time anyway, because as a surgeon, this doesn't change my behavior that much. I now wear my mask in Ralph's instead of the operating room. But besides that, I'm okay with this sort of behavior in the short term. I mean, I miss my Dodgers. I miss my concerts. I miss that. I miss going to Comic-Con. I did that every year. I miss going to my favorite restaurants and hanging out with my friends. But I understand why. And I know it's hard for other people to understand why. And it seems it's hard to process. And we're all getting really tired of this. My son's getting tired of this. My friends are getting tired of this. And I feel sometimes it's like that coach. I'm a high school coach. You can do it.
Just get through it. We're just exhausted. Speaking of, just understanding, you were telling me earlier, I just kind of wanted people to get a sense of your experience too, that you could be wearing your scrubs out and people will actually say stuff to you like, this is fake, or just tell me some of the reactions you've gotten from people that are kind of shocking. It was shocking to me that people would say this to you.
Yeah. And unfortunately, it's not shocking anymore, but I mean, yeah, you wear your mask in public and people scoff at you. I wear my scrubs and people so it's a hoax, right? You doctors, that's how you're paying for your car, right? I was like, no. It's on Facebook. I get attacked all the time for making this stuff up, for, how do you explain that everybody's fine after COVID? How do you explain that, it's only why are we doing this if it only affects 0.2% of the population? Why are we doing this if it only kills 1%? I was like, okay, 1% is still kind of a lot when you're dealing with 330 million people in the United States. Just saying. And we don't even know that's the real number yet. It's really hard to collate data. And everybody, again, you guys don't see how the sausage is made. Normally this gets through peer review and journal articles and it gets analyzed, and years later it comes out. And you guys are getting it live and wondering why it changes. Yeah. And when it changes, you blame us for lying to you.
It's weird times.
I never thought that being a doctor would give people reason to demean and demoralize me, and demean and demoralize nurses, and demean and demoralize people that are just trying to help. And we're also humans. We're just like non-doctors, and we get sick too. But I make sure I do what I can do so my family stays safe, and that I stay safe, and that my community stays safe, that the people that I care about stay safe.
Well, we're getting demeaned and demoralized too for spreading fake news. So I have a little bit of a sense of how it feels. It's like you do this whole article and they're like, well, why didn't you report this or the Spanish flu numbers? I'm like, we have a couple questions here. So this is one. This is actually one I'm curious about too. So how far out from the initial infection have you seen complications come up? I was curious too. Maybe, there's stories of like long haulers and
right,
people that have had very mild cases that are close to me, and I wonder, could this person they're fine now and they've recovered, but could they get really sick like 6 months down the road? So what have you seen as far as that?
So I find it interesting that we're talking about long haul complications in a disease that we didn't know about a year ago.
I know this is true.
So this isn't long haul. This is short term. Normally, short term issues are within the first couple of months to a year of whatever your disease is. Long haul is years out. So we're still dealing with short term issues, even though the lay public says it's, I should be fine by now. You might not be fine, and we won't know what the disease does to you for years. And that's we have to follow this. We don't know. Now, what's funny is you talk about complications, but what if somebody has a trach and they need a trach for a while? Is that a complication? What if they lose their leg? They get over, but they're not really over. A lot of people are talking about like fatigue and psychological issues, which are all real, but harder to measure. It's a lot easier to measure when somebody is on oxygen at home and can't breathe because their lungs are so scarred up, or they're on a whole bunch of new medications that they weren't on before because the damage that the infection did to them didn't heal 100%. And that's not just COVID. Remember, other diseases do this. It's just, we haven't seen a disease like this that's so new, that initially was really hard to detect, that we don't have any tools in our tool belt to treat yet. We can treat the complications, but how many drugs do we have that actually attack COVID? 0.
Wow.
Yeah.
There's nothing to really treat it right now.
We'll get there. I mean, we made a lot of progress in a lot of other diseases, but if we're being honest, there's a lot of common diseases like respiratory syncytial virus. It's RSV. You hear about it every year where RSV peaks and a lot of kids get sick. Still haven't come up with a vaccine for that. CMV, no vaccine for that. I mean, it's hard. And the fact we're doing this so quickly is so encouraging. And I wish it would give the lay public more confidence, but it seems to be doing the opposite. I mean, I'll give you an example. Most people don't want to take the flu shot because they say that it could get them sick, or they don't feel well, or that it doesn't cover all the strains. So why should I even take it? When the reality is they're technically correct, but they also should know that if you get the flu shot and you get sick, your symptoms will be less, which is kind of what we're talking about with the COVID vaccine right now. So more information is better, but then people only kind of hear what they want to hear.
Yeah, is there some concern that people are not going to want to take this COVID vaccine because it's been rushed out? I've seen some polls, it's like 60% of people say, or 40, I think it was 40% of people said they wouldn't take it, which is a huge number.
That's a problem, especially when these are the same people that talk about herd immunity, because they don't understand that this whole concept of herd immunity really depends on vaccinations in the short term.
Could you see the government eventually do like requiring or mandating a vaccine, or maybe there be a requiring the vaccine to travel? Like if I wanted to go, overseas, could you see?
Yeah, it would have been. Can I foresee it? Not today, not with the way our political discourse is.
Yeah.
Maybe 20 years ago, maybe when the political climate was people could disagree and not hate each other. Or when people could disagree and compromise. Now there's no more compromise anymore. There's no listening anymore. It's a lot of yelling.
You're on one side or the other.
Right. And you'd like to think that this is sort of like, here's something bad we could all get behind. I mean, can we all just agree that this sucks and let's all try to get together and make it better? And it does really mean we all have to do our part. And part of it is behaving. And so many people think it's their American right to misbehave. It's their American right to refuse without any logic behind it. We do have a strong independent spirit in our country. I get that. But this is different. So if we had better leadership at whatever level, if we could communicate to the public that this is good, that this will help everybody, we would be better off. I just don't see that happening.
Yeah.
I really don't.
As far as patients coming into the hospital, it seemed early in the pandemic, it was a lot of nursing home elderly patients that were getting the sickest and dying. Have you seen a change in demographic as far as what you're seeing now compared to the beginning of the pandemic?
Yeah, but that's to be expected. I mean, it sounds kind of bad, but you're going to burn off those people first.
Yeah.
They are going to get sick first. And then the people that are going to get exposed are the younger ones, or are the people that are sicker, but they're at home. I mean, they're just, I mean, I think you hear a lot online that the people that got really sick have pre-existing conditions. Well, anything you take a pill for is considered a pre-existing condition. So everybody who has diabetes, everybody has hypertension,
Obesity.
everybody that's overweight, that's all considered a pre-existing condition.
So
So
good percentage of the population has obesity or diabetes.
Over a certain age group, you're looking at 90% if you add everything together.
Yeah.
And if you just take the average 55-year-old person, they're on at least something, or they've had it before, or they have arthritis. Rheumatoid arthritis can be considered an autoimmune disease. People who smoke, they don't fight infections like normal people, especially respiratory infections. That's a pre-existing condition, theoretically. Actually, technically. So they keep talking about, only people with pre-existing conditions get sick. No, that's the average person is somebody with pre-existing conditions. The average person will get sick. And that's what we need to start focusing on. These are just regular people.
What about the people that say, I see this a lot on Facebook, that, this is flu season and a lot of these COVID cases are just flu cases being, diagnosed as COVID?
I'm not allowed to curse. I understand. And this has been one of the most infuriating things. And me personally, I got caught up. Last January, when I looked at the numbers that were given to me by our government, it did look like the flu. And I knew a lot about H1N1. I know a lot about the flu. But within a couple of days to a week, a lot of people in medicine realized this isn't the regular flu. And now I hear these people saying it's just a regular flu. I'm like, our worst flu seasons killed 40,000 people. We're over 200,000 now. This is not the flu by any way. Now, it's a virus. And that's where people sort of stop. They're like, oh, you're going to get sick and you're going to get better. No. And it's so not the flu. I don't know how to, in fact, on a good note, I have a feeling that real flu cases this year are going to go down.
Why? Because people are being extra cautious on everything. Yeah.
Because a crap load of people are wearing masks. And they're not congregating in large public mask-free areas. Haven't you noticed it's kind of strange that some of these outdoor gatherings, whether it's a church or a restaurant or something, they sort of just move all the chairs and stuff outdoors into the parking lot, put a tent on top, walls around it, a door in the front and the back. I was like, that's kind of being inside.
Yeah. Yeah. Mm-hmm.
Because you can't argue that if you are really outdoors and the tables are spread apart, then pretty much the only people that are really going to spread it are the people around the table.
Yeah.
Because it's a respiratory virus. It's people talking, laughing, singing. They're going to expel it to everybody. But if you go to a bookstore with your mask on, you're probably not going to spread it. There's a lot of small businesses that I think are being punished because the bigger ones aren't behaving. Small businesses could do it right, and they're the ones that are getting hurt.
How do you feel about the restaurants being closed? Do you think the smaller restaurants with outside, do you think that should be allowed to remain open? So
I'm just a guy who lives and loves Long Beach, and it kills me that I can't go to the restaurants I want to, and I do takeout whenever I can to support them. But as a doctor, I just know that if you put a bunch of people in an area, and when you're eating, nobody eats alone. They're always with at least one other person. And if they're not eating, they're talking and their mouth's always open. And that's a way you spread respiratory virus. So if we could just shut them down for like 14 days, takeout only, 14 days, let us get a handle on this stuff. And better yet, let's vaccinate some people. So it may not stop them from getting COVID, but at least they don't end up in the hospital.
Wow. Well, and Dr. Mo, what's one of the biggest things you would want people to know about what's going on in the hospitals right now and what you're seeing and what we could possibly see, in the near future?
The most important thing I wish people would know is that we, the medical community, we, the hospitals, the nurses, the doctors, we care about you. And we're doing a lot of good. It's not our fault that there's virus exists. And it's not our fault that we have to shut down restaurants and Dodger games and concerts. It's nobody's fault. It's just, it's a natural disaster. It's an infectious disease. And this is what we have to do. If you want to make this better, we have to do this. It sucks. And sucks isn't even the strongest word, but people are losing their jobs. I mean, if you want to get real personal, a lot of doctors, because everybody says, well, at least you have a job. A lot of doctors didn't make enough to pay their bills this year.
Wow.
You know, we're not doing this. We're not doing this because it's good for us. I would be much happier if COVID didn't exist for a lot of different reasons. And so would the nurses. But I wish the public would know that we're doing our best. Medicine's work. Have a little patience in watching us work to come to a solution for this.
All right. Well, thank you so much, Dr. Mo. I appreciate it. That was, hang in there.
I try.
About you. Gosh, I didn't, I mean, how often are you working with COVID patients? Is it regularly? I mean, daily or?
Who isn't a COVID patient right now?
Yeah, that's true.
Everybody gets, I mean, if somebody doesn't call me to take care of a COVID patient, I have to test them to make sure if they have COVID. And we're seeing people that we've taken care of and then they get tested in the hospital. We have to take care of them. Let's say they got shot. Let's say they, I had to fix them. And then 3 days later, we test them and they end up being positive for COVID.
Oh, gosh.
Yeah. So that's my job. I mean, as far as I'm concerned, everybody has COVID.
Yeah, because you're working on trauma patients like gunshot victims who could have, and wow.
We haven't seen this many gunshot wounds in ages. And
that's what I wanted to talk about too. I forgot. So so you're seeing a surge in gunshot cases here in Long Beach too? And LA County is seeing it?
Yeah, it's not just us. We're seeing it in LA County. We're seeing it elsewhere. We're seeing a rise in violent crime, which has to do with the economy. It has to do with politics. It has to do with frustration. It has to do with everything, the holidays. But yeah, we're taking care of a lot of gunshot wounds, and I can't sit around while some guy's like bleeding to death and wait for the COVID test to come back.
Yeah.
So you just fix them. And then you worry about that later. So, but again, this is kind of what we're meant to do, right? I trained to do this. So we're getting to use all of our faculties, and I just wish we didn't have to.
Do you know some doctors that have gotten it? Some colleagues and medical? I'm sure you have. Yeah.
It's heartbreaking. It really is, because we do the best we can, but and the more people that refuse, and the more people that don't want to wear masks, and the more people that don't want to behave, and the more people that think it's okay to spread, is just going to make it worse for everybody.
Well, we appreciate you, Dr. Mo. You're a hero. And thank you so much for your time, and hang in there. Hopefully it'll get better.
I can't wait to give you all some good news.
I know. I feel like every time I talk to you now, it's,
I'm no fun to talk to anymore. I swear to God. I used to
talk about Dodgers. That was one good thing.
Dodgers, Lakers. Come on. Did you see the Disney Plus stuff? I can't wait for all this Disney Plus stuff to come out. But
that's great. Yeah.
All right. You be good. I'll talk to y'all later.
All right. Thanks, everybody. And we'll try to get some more questions answered later if you have some other ones.
Yeah.
Great. Thanks again. Bye.